Hey, good evening, everyone. My name is Ria Suarez with the Cancer Support Community, and welcome to our webinar, Frankly Speaking About Cancer, Non-Hodgkin Lymphoma, which is hosted by the Cancer Support Community and sponsored by Spectrum Pharmaceuticals. A brief Q&A session will follow the formal presentation, and if anyone should require technical assistance during the conference, please dial 1-866-229-3239 and dial option number 1. So before we start, I'd like to go over a few housekeeping items. Today's webinar is being recorded and will be made available on the Cancer Support Community website at cancersupportcommunity.org/webinars. The format of today's webinar will be as follows. Our presenters will be featured first, and then we will begin the Q&A portion. Thank you to those of you who submitted questions prior to the webinar as part of the registration form. If you'd like to ask additional questions, please feel free to type them into the Q&A box on the right. You may submit a question through the box at any time during the event. At the end of the webinar, you will be redirected to the post-webinar survey. Please complete this survey as your input is invaluable to us. The survey will only take a few minutes. So I'd just like to start by giving a brief background on the Cancer Support Community. So we are an international nonprofit organization that provides social and emotional support to all people impacted by cancer. In 2009, the wellness community and Gilda's Club worldwide joined forces to become the Cancer Support Community. And through that merger, we now provide the highest quality emotional and social support through our network of more than 50 local affiliates and 100 satellite locations and online as well. So our mission is to ensure that all people impacted by cancer are empowered by knowledge, strengthened by action, and sustained by community. And on this slide, this just lists some of the programs and resources that we have. We have our Cancer Support Helpline, our Open to Options program, our Cancer Experience Registry, and our Frankly Speaking About Cancer National Education Program as well. So if you'd like more information on any of these programs, please feel free to call our helpline at 888-793-9355 or visit our website at cancersupportcommunity.org. So for today, we will be discussing non-Hodgkin lymphoma. We'll be identifying some signs and symptoms, going over diagnosing NHL, understanding treatment options, learning about clinical trials, managing side effects, and we'll also be going over the social and emotional concerns of coping with a cancer diagnosis. And then at the end, we have some time for a Q&A portion, as mentioned. So at this time, it's now my pleasure to introduce our featured speakers, Alison Moskowitz, Jill Vanak, and Bonnie Dockham. Alison Moskowitz is a board-certified hematologist and oncologist at Memorial Sloan-Kettering Cancer Center. She received her medical degree from the Albert Einstein College of Medicine and completed her internal medicine residency at Columbia University Medical Center. She began her fellowship training in oncology and hematology at MSK in 2006 and has worked at MSK as an attending since 2010. She specializes in the treatment of patients with lymphoma and leads clinical trials evaluating new drugs and new treatment strategies aimed at improving therapies for patients with lymphoma. Jill Vanak is a board-certified acute care and advanced oncology nurse practitioner at Memorial Sloan-Kettering. She specializes in the care of patients with oncohematologic malignancies, specifically those patients whose treatment includes hematopoietic stem cell transplants. Dr. Vanak has been with MSK in a clinical and research role since 2003. She continued her career at MSK in both a clinical and research role, while completing a doctoral program in health policy and outcomes research at the University of Pennsylvania. Dr. Vanak's current role at MSK includes serving as a founding director of the Homebound Stem Cell Transplantation Program and as a clinical outcomes research consultant in the financial planning department. Bonnie Dockham graduated from Michigan State University with a bachelor's in social science. She immediately pursued her graduate degree at the University of Michigan, graduating with her master's in social work with a concentration in healthcare practice. Bonnie has practiced as a licensed medical social worker both in the inpatient hospital and the Department of Radiation Oncology at St. Joseph's Mercy Health System. Bonnie is the founding program director of CSC and has particular interest in implementing evidence-based practices to create optimal change and benefit to patients and families affected by cancer. So at this time, I'd like to pass the presentation over to Alison.
Thank you so much, Ria. So I'm going to go over an overview of non-Hodgkin lymphoma, and I'm going to go on to the next slide. So there are, just as far as a brief background regarding lymphomas in general, they are cancers that arise from lymphocytes, which are the white blood cells that are in our blood that help fight infections. Non-Hodgkin lymphoma represents the sixth most common type of cancer in adults, and it does increase with frequency with age, although it does tend to be prevalent among children and young adults as well, given that cancer is less common amongst younger people. There are many different types of lymphoma in general. There are over 100 different types, and when we think about how we categorize lymphomas, our major ways that we categorize them are first by using the terms Hodgkin lymphoma and non-Hodgkin lymphoma. It turns out that Hodgkin lymphoma is really just one disease, and then every other type of lymphoma falls under the category of non-Hodgkin lymphoma. And this talk going forward will focus on all of those other types of disease that we call non-Hodgkin lymphoma. But given that the term non-Hodgkin lymphoma is so nonspecific, we have some additional ways to further characterize these diseases. One is to characterize them further as B-cell types of lymphomas and T-cell types of lymphomas. This reflects the fact that we normally make B cells and T cells in our body, and they each have different roles in fighting infections, and either one of those types of cells can develop into lymphomas. And it turns out that the B cell types of lymphomas are more common. Another way that we further characterize these are by thinking of thinking of the non-Hodgkin lymphomas as either slow-growing types of lymphoma and more fast-growing types of lymphoma. And I'm going to talk about that a little bit more a little later because that has an impact on how we approach these diseases. Sorry. So as far as I mentioned, the B-cell lymphomas represent the more common type of non-Hodgkin lymphoma. And just to mention the most common types of lymphomas, diffuse large B-cell lymphoma represents about 30% of all of the non-Hodgkin lymphomas, and that's the most common type. The second most common type of non-Hodgkin lymphoma is called follicular lymphoma. And then the other types of lymphoma happen to be much less common, including mantle cell lymphoma actually only represents about 5% of the non-Hodgkin lymphoma. So as far as the specific signs and symptoms of lymphoma, they're very non-specific. Many of the symptoms that someone may have that lead to a diagnosis of lymphoma could be symptoms of other things such as infection, and sometimes it's not always so easy to come to the diagnosis. And sometimes patients don't have any symptoms at all, and occasionally lymphoma can be found incidentally. But some of the specific symptoms that someone might have is potentially a swollen lymph node that they may feel in their neck or underneath their arm, potentially pain somewhere in their body that might reflect because it might be due to lymphoma pressing on a particular area in the body. Sometimes people can have itchiness or tiredness, and then some some of the classic symptoms are fever, weight loss, or night sweats. Some patients will have those. Again, those are symptoms that can sometimes indicate something else is going on besides lymphoma, such as an infection, but sometimes those can be a symptom of lymphoma as well. As far as the tests that we do when we're first trying to make the diagnosis of lymphoma and then also trying to look to see where the lymphoma is in your body, these include a physical exam. We do blood work and blood tests, imaging tests such as CAT scans and PET scans, and then the initial to make the initial diagnosis, it typically involves a lymph node biopsy or some type of biopsy in order to look to see, to make the diagnosis. If sometimes, occasionally, it's not a lymph node that's involved, and so it might be a biopsy of some other part of the body. And then often in our evaluation of figuring out where the lymphoma is in your body, a bone marrow biopsy is done. So just as far as an example of what these imaging tests look like when we're trying to figure out where the lymphoma is in your body. The test on the, I'm just moving this arrow a little bit, the test on the left is a PET scan, and we use this test to help us stage lymphoma, which is basically just determining where it is. And as you can see, a PET scan will often light up, particularly in certain types of lymphoma, they will appear bright on a PET scan, and that can allow us to understand if the lymphoma is actually, if there's active lymphoma in the body. In this particular PET scan, there is an active area in the middle of the chest, which is the arrow should be pointing to. And that's really the only actual abnormality on this. There are other areas that are lighting up on the PET scan that actually represent normal areas that should light up, such as the heart or the bladder. On the right is a CAT scan, and we use these. There are certain types of lymphoma that do not light up on a PET scan, and in which case we would use a CAT scan alone to figure out where the lymphoma is in the body. And a CAT scan really also complements a PET scan, in particular allowing, it's the best way to really measure the size of lymph nodes. And on this particular CAT scan, you can see there's very tiny lymph nodes underneath this person's arm, and those are likely normal size lymph nodes, but that's this is really a helpful way to look at these. And I wanted to give you a sense of what it looks like when we're making a diagnosis of lymphoma. This is what it looks like under the microscope when we do a lymph node biopsy for someone who has lymphoma. Use the arrow. The top left picture is a general stain of a lymph node, and that basically allows us to look at the what the cells look like, and that gives us a clue of whether there's abnormal cells there and whether or not this might be lymphoma. And then our pathologist will then go on to do additional stains to help clarify what these cells are. And in particular, this picture on to the upper right is the CD20 stain, and which outlines the abnormal cells, and that indicates that this is a B cell type of lymphoma. So this is one of the more common types of lymphoma. And then the additional stains here are helping us to further clarify which particular type of lymphoma this is. And so this is a workup that's done every time someone is diagnosed with lymphoma, and there's a different panel of stains that we would do that help us figure out which one of the many different subtypes that a particular patient's lymphoma could belong to, and this makes a big difference in which treatments that we choose. As far as categorizing these hundreds of different types of lymphoma, as I mentioned, the major categories are the more slow-growing types of lymphoma, or sometimes we use the word indolent, aggressive lymphomas, and then highly aggressive lymphomas. The slow-growing types of lymphomas, they are generally considered not to be curable, but they, in general, you can, often can think about them as a more chronic disease. They often are responsive to treatment such as chemotherapy or radiation therapy, but they also don't always require treatment. At least sometimes at the time of diagnosis, they don't always require treatment, and sometimes they can be monitored. And the most and an example of a slow-growing lymphoma is follicular lymphoma. In contrast, the aggressive lymphomas often are curable, and they often do grow much faster. And basically, we consider the aggressive lymphomas as a lymphoma that really you can't monitor, that you really we need to treat and we need to try to cure because it can be life-threatening. But the benefit, the upside is that they can be curable. And the most common example of this is diffuse large B-cell lymphoma. And then finally, the highly aggressive lymphomas really grow at a very rapid pace. Even in the matter of days, the size of lymph nodes can change. And the most common example of this is Burkitt lymphoma, which also happens to be highly curable. So I mentioned that one of the goals after we've made the diagnosis of lymphoma, we want to figure out where it is in your body, and we call that staging the lymphoma, and it's basically figuring out what is the distribution within your body. So when we call a lymphoma stage 1, that really means that there's just one lymph node area involved, so either possibly in one's neck or underneath the arm. Using the term stage 1E, that's the E stands for extranodal, and so that means that the lymphoma is still very, very localized. It's in one little spot, but it's involving an extranodal area. So an example of that is that sometimes someone can have a lymph node that's arising in the nasal cavity, for example, but it's only really in that one area. We would call that stage 1E disease. Stage 2 disease means that there's 2 or more lymph node areas involved, but they're still on only one side of the diaphragm, so either on the upper part of the body or on the lower part of the body. So an example of this could be that with someone having involvement of their neck and underneath their arm. And then finally, stage 2E means that they have involvement of more than one lymph node, but also there is extension from one of those areas into a non-lymph node area. So, for example, someone could have a lymph node in the middle of their chest, and it could be also touching and growing into the lung, and we would potentially call that stage 2E because it's extending into the lung. Finally, stage 3 and stage 4, we would consider these to be advanced stage disease. And this is actually, it's more common for lymphomas to present as advanced stage. So stage 3 refers to lymph nodes that are involved both on the upper part of the body, so above the diaphragm, as well as on the lower part of the body, so below the diaphragm. And then finally, stage 4 means that in addition to that, there is also involvement of areas outside of the lymph nodes, so such as the bone marrow, bones, liver, or lung. So I'm going to briefly go through treatment options. Treatments for lymphoma very much depend upon the type of lymphoma that is diagnosed, whether or not a patient's having symptoms, and what is their stage and distribution of their disease. And so treatments tend to really be individualized. The particular treatments that we could choose from include watching and waiting, so monitoring, as well as chemotherapy, radiation therapy. There are targeted therapies that some of which we're using very commonly. And then finally, stem cell transplant is sometimes incorporated into treatment. So the watch and wait approach might be something that is appropriate for patients who have the more slower growing types of lymphoma or the indolent types of lymphoma. So an example is, for example, I mentioned follicular lymphoma represents this type of lymphoma. Another example is marginal zone lymphoma. These lymphomas, because they grow slowly, one can live with them potentially for many years before they develop any symptoms from it. And we typically do not necessarily treat them unless they are causing some symptoms or causing some problems. And so the problems that someone might develop that would indicate that we need to treat them is having lowering of their blood counts, so such as anemia, or lowering of their platelets, or having symptoms such as discomfort from a growing lymph node, or a lymph node potentially being too close to an organ such as your kidney, and which would push us to want to treat it and to try to shrink that down. So when someone is being monitored, we are watching them, relatively closely, and and the ways that we watch patients are with physical exams, with blood work, and as well as with occasional imaging scans. And typically, when we first meet a patient who we're going to monitor, we typically do these evaluations a little bit more frequently, and then depending upon how fast things are changing over time, we might reduce the frequency of visits and scans over time. Sometimes we can monitor people this way, potentially for years, but it's really important that patients continue to follow up, and and in between visits, if I tell my patients that it's just very important for them to let me know if they develop any new symptoms or anything that's concerning, because we can always schedule an appointment or a scan sooner to see if there's anything new going on. Many people who present with lymphoma do require chemotherapy, and this is many of the chemotherapy drugs that we still use have been around for quite some time, and one of the most common regimens that we use for non-Hodgkin lymphoma is a regimen called CHOP, where each letter stands for a different chemotherapy drug. Well, the first three letters are chemotherapy drugs that are infused into a vein, and then the fourth letter, the P, stands for prednisone, which patients take by mouth. This is the most common regimen given for the more aggressive lymphomas, but sometimes we do consider giving it for the slower growing lymphomas as well. We often combine this regimen with a drug called rituximab, which is actually an antibody, kind of like how we make antibodies that we normally make antibodies to fight infections. Rituximab is an antibody that was designed to bind to B cells and recruit your immune system to help attack those cells. And so rituximab is an example of a targeted therapy that when combined with chemotherapy helps make it more effective. And so we often, for treating B-cell lymphomas, are often using a regimen called R-CHOP, where we're including the rituximab. Sometimes we include radiation therapy in our treatments, particularly patients who have lymphoma that is localized to one part of the body. So, for example, if someone presents with disease that is localized in the upper part of the body, they may end up getting potentially chemotherapy followed by radiation therapy, or they may just, or sometimes, depending upon the diagnosis and where the disease is, we might recommend radiation alone. I briefly mentioned targeted therapy, particularly rituximab as an example of targeted therapy. There are many other types of therapies that we would consider in this group of targeted therapies. Sometimes antibodies can be attached to, can be linked to either chemotherapy or radiation therapy that basically works, has the effect of the antibody can then deliver chemotherapy right to a particular cell that it's specific for. So it can end up reducing toxicity to some of the surrounding cells and make it a little safer, but more potent for actually getting rid of the lymphoma or the cancer. And so an example of, radioimmunotherapy is an example of that, where it's an antibody that's actually attached to radiation and works by targeting radiation right to where we want it to go, which is where the lymphoma is. The benefit of targeted therapies is that we get the treatment where we want to go. It's targeted, and it's associated potentially with fewer side effects because it has less of effect on the surrounding normal organs and tissues. So as I mentioned, antibodies have become a very important part of our treatment, and rituximab is one of the most common ones used, but now there are newer versions of antibodies that we're using commonly as well. So moving on to stem cell transplant, this is a type of treatment that sometimes we recommend for patients based upon what their particular diagnosis is. Sometimes it's recommended as part of their frontline treatment, and sometimes it's recommended if their lymphoma comes back. And I'm just going to talk briefly about what a stem cell transplant is. Stem cells are cells that are basically in our bone marrow, so inside our bones, and they give rise to our new blood cells and our immune system. We can actually collect these stem cells from people's blood, so either from a patient's blood or from a donor's blood. We have ways of collecting it where we don't necessarily have to collect them by taking it out of the bone marrow, which is a little bit more involved. So when someone is getting a stem cell transplant, they first get a course of either chemotherapy or radiation therapy that is aimed to reduce the patient's immune system and also potentially provide some effectiveness against their lymphoma. And then after they receive the chemotherapy, they would get an infusion of the stem cells that go into the blood and find their way back into a patient's bone marrow and give rise to the cells that they need, such as their blood cells. There's two different types of stem cell transplants. An autologous stem cell transplant uses stem cells that are from the particular patient, and in general, the goal when someone is getting an autologous stem cell transplant, the real treatment is the chemotherapy or the radiation therapy that the patient's getting. It's just that the chemotherapy is very, very strong, and in order to allow the patient to recover adequately from that treatment, the stem cells are given after the chemotherapy to help them recover. So the stem cells in that situation is not actually the treatment. It's really just a rescue or a way to recover from the treatment. And the true treatment in an autologous stem cell transplant is the actual chemotherapy that the patient gets before getting the stem cells. In contrast, an allogeneic stem cell transplant uses stem cells from another person, and the goal of that is to give the patient basically a new immune system that is going to hopefully recognize any residual lymphoma that the person has in their body as foreign and help attack it. So it's really an allogeneic stem cell transplant is really an immunotherapy that's aimed to try to further help the patient fight their lymphoma. Patients who get an allogeneic stem cell transplant do get chemotherapy or radiation therapy before the stem cells, but the goal of that is really to get the body ready to accept a new somebody else's stem cells and somebody else's immune system. And so the treatment in the allogeneic stem cell transplant is really, it's considered immunotherapy as opposed to the autologous stem cell transplant, which is really the chemotherapy is the treatment there. In general, when someone is getting a stem cell transplant, whether it's an autologous or an allogeneic stem cell transplant, patients often are admitted to the hospital for somewhere around 3 to 4 weeks while they're getting the treatment and then recovering from it. And I'm going to briefly mention clinical trials because they definitely play a big role in our treatments. I see that somebody asked about. I guess we'll talk about questions towards the end. I see someone asked why we didn't talk about bendamustine or ibrutinib, which we can talk about in the end. We really tried to make this an overview, but I can mention this.
Alison, if you want to mention that now, you can feel free to do that.
Okay. Well, bendamustine is an old chemotherapy drug that has become much more has been used much more recently in the U.S. That we do use for various different types of lymphoma, and it often bendamustine is used, but sometimes we choose it as a frontline setting for some of the slower growing types of lymphoma, such as follicular lymphoma. And we typically, in that setting, would combine it with rituximab. Ibrutinib was recently approved for mantle cell lymphoma and chronic lymphocytic leukemia, and it's also certainly becoming, playing a big role in our treatments. And so it just, it's hard to. There's so many different treatments that are that are available at this point, and so it was hard, and really the treatments that we choose really depend upon the patient's particular diagnosis and where they are in their treatment and whether they've had treatments before, and so it was difficult to mention all of these, and so we really kept it pretty simple. Just moving on to clinical trials. I do think that patients who enroll in clinical trials, they often have the opportunity to potentially get more attention, and potentially have, access to newer drugs that might have more, may end up providing them with benefit. Sometimes clinical trials make sense early on in your treatment, and sometimes it's something that you consider if your lymphoma has come back and you're looking for more options. Each clinical trial has very specific eligibility criteria as far as determining, and often they're particular about what type of lymphoma you must have, and also certain characteristics of who you are and your disease. And that's something that your doctor would help determine if you're eligible for any particular study. I do think that people who end up going on clinical trials, they often get a lot more attention because there's a whole clinical research team that ends up taking care of you. And so often you can get some of the benefits of that. And of course, there's a lot of the newer drugs that are now available, all were evaluated in clinical trials, particularly, including ibrutinib or bendamustine. And there's a lot of exciting drugs that are currently undergoing evaluation. And as far as learning more about clinical trials, particularly, often it will come from your doctor, but a very helpful website is the clinicaltrials.gov website, which you can search for clinical trials and based upon your particular lymphoma. And, this is something that you can always print out from that website and bring to your doctor and ask them if it's something that applies to you. So with that, I think I'm going to hand over the presentation to Jill Vanak, and then I think that at the end we'll be able to go through some of your questions.
Great. Thank you so much, Alison. Again, my name is Jill Vanak, and I am so pleased to be able to speak with you all tonight. Just wanted to review a brief portion on the management of side effects. We are going to talk about very common side effects as related to treatment, and I just want you all to remember, of course, that the list of effects that we're going to discuss is not comprehensive by any means, but we really wanted to take this time to review some of the most common effects. It's important to know and remember that everyone reacts differently to treatment. Each treatment works a different, unique way in the body, whether it's a systemic treatment or a targeted therapy. It's important to know that each class of drug is going to have its nuanced side effects or more common side effects related to that treatment, and you might never experience what we list as a common side effect, but might have the more unique ones. Each person is quite different. It is important, and the overarching concept is that being prepared and knowledgeable about side effects and what you might face and encounter will absolutely help you throughout the treatment process. Some of the side effects listed here, we have them listed under chemotherapy. So yes, chemotherapy can and does cause side effects such as the ones listed here, but it's important to remember that these side effects could occur with radiation, targeted therapy, etc. So they really are universal. As Alison described chemotherapy, I just want to review a little bit about what she said to give you the rationale about why these side effects occur, because it's just important to understand. In speaking about chemotherapy alone, the goal of the chemotherapy overall is to destroy cancer cells. Traditional chemotherapy drugs do work by killing cells that divide rapidly. And as they wipe out fast-growing cancer cells, they also damage fast-growing healthy cells. With chemotherapy, it is a systemic treatment, so there's not a targeted part of this cell cycle for some of these drugs. So damage to healthy cells can lead to side effects, such as some of those listed on the slide. And what we have listed here, or common effects that we see, include fatigue, infection, damage of cells that line the mucous membranes from the mouth all the way to the anus, all throughout the body. And this can lead to mouth sores or mucositis, diarrhea, and other gastrointestinal issues. And damage to the cells at the roots of hair follicles is what can lead to hair loss. So again, each person with cancer does react differently to chemotherapy, to other treatments. Management of these side effects is improving. It's a huge source of research from our end. It's something that we're very interested as providers and clinicians to overcome and to more effectively manage side effects. The important thing to remember is that in order for your providers to provide the best treatment, the most proper management of your disease, you have to let them know details about your symptoms and what you're experiencing. So overall, something that we have found that really does help with this is keeping a journal of side effects that you bring with you to appointments. Some people have that go-to person that they bring with them. Some people put things in a notebook. But really just keeping a journal, maybe noting the date and time that a side effect occurs, how long it lasts, how strong it is, how your daily activities are affected. These things are really important to note and bring to your provider's attention. Just wanted to go through a bit of management about some of the effects that we've listed above. In terms of hair loss, it's important to remember not all anti-cancer medications will cause hair loss. This is absolutely a conversation that you need to have with your physician, your nurse practitioner, your provider, and he or she will be able to tell you, yes, you can expect this, or no, you won't expect this. Usually, when hair loss is a side effect, it occurs about 7 to 21 days post that treatment. And again, it's absolutely something that affects self-image. It affects body image. Some people choose to shave their head. Some people choose to wear a scarf, a turban. It's just important to reach out and know what types of programs and what support system there is within your institution. In terms of mouth sores, a very clinical word that you are going to hear is the word mucositis. So just rule of thumb, anything ending with itis usually means inflammation. So with mouth sores, basically chemotherapies and some directed radiation treatment can cause sores inside of the mouth because that treatment affects the mucus lining of the throat and the digestive tract. So these sores are called mucositis, and we need to manage them because they can cause pain, infection, and can make it difficult to eat, to drink, and to swallow. Once the treatment ends, the mouth sores disappear, and normally at a rapid pace as you recover, but it's important to protect your health and to know about these side effects. Important for management includes routine visits to your dentist before treatment begins, and then checking in with your provider about oral care, using soft bristle toothbrushes, non-irritating toothpaste, and always remember that fluid intake really can assist with this. There are medications that can absolutely aid in the management of mucositis. You'll hear the term magic mouthwash, which is a combination of some numbing agents and some other medications. Some opiates have to be used. This can cause some pain, and some over-the-counter medications as well. In terms of loss of appetite and nausea and vomiting, these are, again, common side effects that occur while you are undergoing treatment, especially with chemotherapy. It's important to know that there are medications, especially surrounding nausea and vomiting. Research continues to be done on receptors and patient response to different types of medications. I think one of the most important things to know about nausea and vomiting and its management is it's important to talk to your nurse, to your doctor, about how to take your medications. Some anti-nausea medications, or emetics, are designed to target acute nausea. Some are designed to be taken for a specific number of days to prevent long-term or chronic nausea. So it's very important to speak to that provider and be aware of how it's best taken. There are a number of classes of drugs for nausea, including anti-anxiety treatment, stomach acid blockers, corticosteroids, just all these different classes of drugs which target different receptors. And fatigue. Fatigue, overarchingly, is the number one side effect and complaint of any type of treatment that is given. And a quick, down and dirty definition of fatigue is feeling tired, really, really tired. And it can be related to a number of factors. It's related to the cancer itself. It's related to the treatment that you're getting. And it's important to remember it's absolutely related to the emotional aspects of coping with cancer and cancer pain. It's that mental fatigue. In terms of treatment for fatigue, if the underlying cause is an anemia or low red blood cells, so if you have a low red blood cell count, and remember chemotherapy will lower all of your blood cell counts for a period of time, you're getting less oxygen to your body. Less oxygen is circulating throughout your system. So if that is the cause, treatments could potentially include some red blood cells or basically getting a blood transfusion. It could consist of some erythropoietin shots or things along those lines. But really, if the fatigue is due to that treatment itself, the cancer itself, medication might not be the answer for all cases. Again, management can include taking several short naps or breaks, taking walks or trying to incorporate exercise into your daily routine, doing the activities you enjoy but with a shorter time frame around them, saving the energy that you have for activities you most want to do, and really just always alerting your team to what is going on in terms of that level of fatigue. So radiation therapy, Alison did speak to radiation therapy and the use of radiation therapy with treatment of non-Hodgkin's lymphoma. And again, for this particular disease, or rather for these different types of cancers that are all called non-Hodgkin's lymphoma, it's important to remember that radiation is generally confined to the lymph nodes, areas directly surrounding the lymph nodes, or an extranodal site or a site outside of the lymph node system if it is a source of disease. So with that being said, radiation therapy can absolutely cause side effects that are listed here in terms of damage to surrounding healthy tissue, skin changes that look and feel like sunburn. The areas where the radiation is being directed or targeted absolutely can become reddened and raw. It's very important to speak with your radiation oncologist, who you will see, as well as your nurse, regarding some different approaches that you can take to this, including the use of certain medications, creams, topical ointments, etc. Also, they will give you some preventative tips before you start radiation in terms of avoiding specific types of lotions, scented deodorants, things along those lines. Again, as we spoke about, a lot of these side effects are going to run across families. Some side effects that you'll see due to chemotherapy drugs are due to radiation as well, including that dry mouth, that upset stomach, or that gastrointestinal issue, which can include nausea, it can include vomiting, diarrhea, things along those lines. And anxiety absolutely is a very real concept. And remember, we're speaking a bit about side effects in terms of an acute or short-term time component here. We'll get to long-term side effects in a few slides. But it's important to remember that there are aspects of your treatment that will absolutely carry over. Our hospital is located, many of our patients have to cross a bridge. A lot of patients tell me that as soon as they cross the bridge and get on that bridge, they start vomiting or get very anxious and feel very nauseous. Remember that there could be long-term effects in terms of things along those lines, and it's important just to be aware of your triggers or things along those lines. Stem cell transplant. So again, it is important to remember this is not necessarily an absolute component of your therapy for non-Hodgkin's lymphoma, but it is a common therapy in treatment of the disease. Again, as Alison explained, in very brief terms, a stem cell transplant is a medical procedure in which diseased bone marrow is replaced by highly specialized stem cells that basically develop into healthy bone marrow. And again, there are two types. They are quite different. Autologous stem cells is the process in which your own stem cells, which we have previously collected, are reinfused into your body. And an allogeneic stem cell is where donor cells, cells from another person, are reinfused. So you'll absolutely speak to your provider about the nuances of those types. Stem cell transplant, the side effects really mimic those of chemotherapy, because remember, you're going to get a slug of chemotherapy to attempt to wipe out the disease prior to getting these stem cells placed back in. One big effect, low blood cell counts. And with a stem cell transplant, we expect your counts to be lowered for a period of time that's a little bit more lengthy maybe than with a single agent chemotherapy. So in terms of speaking about low blood cell counts, a low white blood cell count is deemed neutropenia. You'll hear that word a lot. So the term neutropenia refers to an unusually low number of neutrophils, which is a type of infection-fighting white blood cell in the body. These types of cells play a key role in maintaining your health because they seek out and destroy harmful bacteria. So it's important to remember that chemotherapy does reduce the number of neutrophils in the body, and this can lead to fever and infections. You can usually expect your counts to drop about a week after each round of chemotherapy ends. They often reach their lowest point about 7 to 14 days after treatment. If nothing else, it's important to remember you should call your provider if you have any of these, including fever, very sore mouth or gums, pain or swelling, cough or shortness of breath, an ear infection or sinus infection that's just come on. It's important to remember that because you have lower numbers of these infection-fighting cells in your body at this point in time, you are susceptible to a number of things, and your body cannot fight them off as they would at your healthy state. So that's why it's so important for you to make your team aware. There are treatments including antibiotics, growth colony stimulating factors, things that will assist in preventing and treating that infection. In terms of tips to avoid or prevent infections, avoid people with colds, bronchitis, any infectious process, especially during those low count periods. Wash your hands regularly. We cannot stress it enough. Take care of your skin. You really want to speak to your providers about activities really such as gardening, things that expose you maybe to fungus or different types of elements which you don't want to be exposed to during this time period. You'll definitely want to be careful with food handling, really cooking everything thoroughly. You want to avoid cleaning cat litter boxes, and you really want to do common sense things like discarding sponges, discarding old makeup, anything along those lines. Again, these are very specific topics that you'll speak to your provider about. And finally, in terms of these common side effects, this slide deals a bit more with long-term side effects. Again, this is not comprehensive in the least, but many of these effects listed here do occur in the long-term setting or can occur. They're just things to be aware of. Again, rightly so, people are very focused on the treatment at hand, in curing the disease, in getting the disease under control, and in tackling these side effects as they come. It's important to remember, though, that on the other side, for lack of a better word, it's really important with survivorship and that concept to really speak to your doctors and your providers about these long-term effects that you need to be aware of just in order to manage your health. So in terms of these effects, infertility can occur with these treatments, again, with some treatments more than others. Early menopause is absolutely something that we manage and that we see. It's important to note because some types of cancer treatments affect the endocrine system, which consists of glands and other organs that are responsible for making hormones and producing eggs and sperm. So symptoms of menopause can be caused by cancer treatment, and oftentimes they can be worse than the symptoms of natural menopause because the decrease in hormones happens at a quicker rate. So this is important to know and to understand and to really ask for assistance in managing these symptoms. Damage to the lungs can occur. Again, bleomycin is a type of chemotherapy that was notorious for lung damage and things along those lines. We have come a long way in terms of managing these side effects, but again, each drug has that certain nuance or that certain side effect panel or profile. Damage to the bone. So in terms of bone, joint, and soft tissue problems, cancer survivors who receive chemotherapy or steroids or hormone therapy, and particularly those people who are not physically active, can develop thinning of the bones or osteoporosis or joint pain. Really, to lower your risk, things that you can do: avoid tobacco products, eat foods that are rich in calcium and vitamin D, get on an exercise regimen, and limit the amount of alcohol that you drink. Damage to the eyes that can affect vision, things along those lines, and really the one that is always prevalent or that we get asked about a lot, development of a secondary cancer. So secondary cancer, either a new primary, meaning a different type of cancer, that develops after treatment for the first type of cancer, or cancer that is spread to other parts of the body from where it started, can develop as a late effect from previous cancer treatments. Chemotherapy, radiation therapy can can damage the bone marrow stem cells and can increase the chance of developing myelodysplasia, which is a blood cancer, where the normal parts of the blood are either not made or are abnormal. So it really is important to speak with your doctor about ways to lower the risk of a secondary cancer or just the signs and symptoms to watch for. The rate of a secondary cancer, again, is dependent on your primary cancer, on you as a person, on comorbidities. But again, it's important just to know the statistics around that. So finally, side effects from treatment are often short-term, but again, you can experience long-term effects that occur in that survivorship phase. Many of the treatment side effects that we talk about do go away after treatment ends. So it's important just to get a timeline for yourself. Talk with your healthcare team. Have them tell you what you can expect, what might be common, and really work with them. It's a team effort to manage. There are side effects of treatment that can be long-term, like we talked about. Again, always important just to keep that conversation going with your team and making them aware of what is going on with you. Finally, I will say that, again, many patients say, I don't want to be a bother. It's probably not that big a deal. Side effects are a big deal. We are absolutely worried not only about your disease process, but about you and how you're handling the effects. Sometimes the side effects from treatment can be worse than the disease itself for that period of time. We understand that we want to know what's going on. And finally, in terms of you being proactive, if you're experiencing side effects that are at a certain level or a certain severity, absolutely it can be a note to change treatment, to reduce some doses of treatment. It absolutely is vital information that your team needs to know and needs to be aware of. So please do not hesitate to speak up and be proactive in that. And with that, I'm going to go ahead and pass this off to Bonnie Dockham to talk about social and emotional concerns.
Well, good evening, everyone, and thanks for having me with you tonight. I know that Jill noted a couple things about some social and emotional concerns that are common when dealing with a cancer diagnosis, but I'm going to talk a little bit more specifically about what some of those might be and also what you can do to take control of some of those issues. So addressing the social and emotional issues is an imperative part of managing a side effect from treatment. So oftentimes when people think about side effects, we only think about those things that Jill just talked about, the fatigue, the nausea, some of those physical issues. But the mental health and the emotional side effects are just as important. The slide here talks about some of the common side effects like feeling shocked or alone. There are a number of people who actually do develop an adjustment-related depression related to their cancer. So this can be really hard to tease out because a lot of the side effects of cancer treatments are also symptoms of depression. And so it's kind of difficult to tell sometimes, are you having a normal adjustment reaction or are you headed down the path towards an adjustment-related depression? And quite a large number of folks do actually end up needing treatment for clinical depression as well during their cancer treatment for managing those side effects. And that's not something that they say on long term, but it's something that people often do to get them through their treatment. So it's important to know the symptoms of depression and anxiety and how they might differ from the side effects from treatment. So as we define depression and some of the symptoms of depression, as I said, some of them do overlap with side effects of treatment, like changes in appetite or changes in sleep patterns, things like that. So sometimes they're easy to mistake for, oh, this is just a side effect from my treatment. But there are certain things that you as a patient or as a family member can look for in your loved one or in yourself to determine if the feelings that you have or are experiencing are in fact something that need a little bit more attention than having a couple bad days. So I'm just going to talk about those a little bit more particularly. So feelings of hopelessness or irritability. Irritability is a really big one when it comes to depression, so people being less patient with family members or friends than they generally are, maybe a little bit more snippy than usual. lack of interest in things that people previously enjoy. This is a really common one too, so people just don't feel like doing anything, and that can be confused with, well, I'm tired, but we really encourage people to look a little bit deeper than that. Is it that you're tired, or that you're just not going to enjoy yourself, that you're just not interested in going out or spending time with your grandchildren or whatever that might be? Really think about what is happening. Also, this is important for family members to notice about themselves, not just for the patients. The Institute of Medicine released a report in 2007 called The Cancer Care for the Whole Patient. And in that report, it was the first time that a really accredited medical organization talked about the importance of the social and emotional issues being addressed for not just the patient, but also the family members. I think it's really important that we recognize that these emotional issues are not exclusive to the person undergoing treatment, but the people who love them as well. So it's important to be aware of some of these things so that you can reach out for assistance if you do think that maybe you are dealing with an adjustment-related depression instead of just some normal side effects. And adjustment-related depression is a normal side effect as well, but I think too many people suffer from it when there is definitely help available. Another thing to know is that there are some common times of crisis that you can know about ahead of time, to know that these are going to be periods of time where emotionally it's going to be a little bit harder than other periods throughout your treatment. Cancer treatment emotionally is often a number of peaks and valleys, ups and downs, and the emotional roller coaster that goes along that cannot be entirely predicted. But there are some periods of time that we know tend to be more stressful for others. And if you know that ahead of time, you can kind of prepare yourself and prepare your support network for a potential difficult reaction. So some of those times include, obviously, the time of diagnosis. There's a heightened emotional response at that time. But also at the start of treatment, anxious about the uncertainty that comes with this. How will this affect me? Is it going to work? Change in treatment. So sometimes people have more than one regimen where they start with one and change to another, whether that's because they are unable to tolerate the side effects or because that was part of the plan all along. But those changes really can heighten anxiety and fear as well, because it comes back to that uncertainty. On the end of treatment. So this is a really common one that people don't always expect. Family members and friends and patients alike often think that this is going to be a very celebratory time, and it often is, but it often is a celebratory time and a really highly emotional time. Sometimes people feel like they've been putting their fires out in order, so they've dealt with all the physical stuff, and now all the emotional stuff comes creeping in, and it often hits them like a ton of bricks. And additionally, family members and friends say, "Woohoo, you did it! We're done with this." But the long-term emotional side effects of what just happened, how did this affect my body? I'm worried about recurrence. What can I do to get my life back? I've been out of work for this period of time. How do I transition back to, quote, what my life used to be or normal? And so that's often a really difficult time for people. And it often is surprising because people are not expecting that. So being aware of that is a really important thing. If there is a progression or recurrence during treatment, that's often a time of crisis as well. And then as you move forward with long-term survivorship, follow-up scans and doctor's appointments, as Jill mentioned, even just crossing over that bridge. I have a similar situation at the cancer center that I used to work at, where there were these large automatic doors, and people used to talk about stepping and walking through those large doors, and even just the act of doing that brought on a lot of anxiety. So that's really important to know about as well. So ways to cope. Here are some a pretty simple list of things that you can do. Obviously, talk to people who you trust, find a support group or an online resource. I think that it's really important to know that there is no one-size-fits-all response to how a person should cope. Some people know that a support group is actually going to be unhelpful to them. Maybe hearing other people's stories makes them more worried. Maybe knowing that maybe they've had a negative experience in individual counseling in the past, and so they're not comfortable taking that approach. So there really is no one-size-fits-all, but talking to a social worker at the cancer center where you're receiving your treatment is a really great start, because they should be able to talk with you about your individual needs and really try to shape a program for you that fits for you. At the Cancer Support Community of Greater Ann Arbor, I meet with all of our new members, and we talk about their particular needs and concerns, as well as, you know, what helps connect their personality to healing. And so some people know that they want to come to support group and know that they're going to be really active in that, while others just want information. They want to come to nutrition programming. That gives them a sense of control, knowledge. Other people say, I really only want to know the very, the very minimal amount of information, and, leave it up to my physician. So it really is unique to each person. But mind-body programs for stress relief and exercise are really, really wonderful. I think a lot of times people think that how could I possibly exercise when I'm so fatigued? But there's quite a lot of research that relates exercise, particularly yoga, and cancer and chemotherapy-related side effects as a very beneficial modality to treating those side effects. So yoga and exercise has been shown to improve depression and anxiety. It has helped with chemotherapy-related fatigue and insomnia. It's not uncommon that people feel unable to sleep, yet they're so fatigued. And when people aren't getting enough sleep or feeling fatigued, that also affects your emotional state. It makes it difficult to really deal with the situation at hand. So thinking creatively about building a program to take care of yourself both physically and emotionally is really important. And the exercise can be very, very minimal. Getting outside and go for a walk. People often talk about feeling confused or having trouble thinking, and there are something called chemo brain that I'm sure that you've all heard of. But there also is the emotional side effect of being easily confused or unable to concentrate. That's a really common side effect of depression as well. And getting outside, being in nature, there are studies that show that can help with some of that emotional side effect as well. So journaling, Jill actually talked about journaling a little bit already. This one is really helpful for people who like to take some solace in having control over things where there oftentimes isn't a lot of control. So this gives a really organized opportunity for people to know exactly, when they're feeling a certain thing, and also really helps the healthcare team to know, what your side effects are. This is a really good task for family members to do if it's about keeping track of your treatment and your side effects and medication and all that kind of thing, because it is often that family members feel a pretty significant sense of helplessness, and doing something concrete like this really can make family members and people that love you feel involved and helpful. Journaling in terms of your emotional response is really helpful in the sense that it provides an outlet for people to really get some of those feelings out without the vulnerability of being in a group or in counseling or fear of being judged in any way. So a lot of people find that to be very helpful and healing as well. So finding support. So again, we talked about, how there's not one size fits all with this, but realizing that support may come in the places where you're not expecting. Family and friends are very important, but we often find that the people that maybe we're expecting to be the most supportive are not, and vice versa. So people learn a lot about how other people deal with stress and with struggle through their own diagnosis. So be aware that sometimes people are acting because they're fearful of perhaps saying the wrong thing, or asking too many questions or too little questions, and that people who care about you often feel anxiety around those kinds of things. So to be really honest with the people in your life about what you need and how you need it is the key to having and building a very successful support network. And then talking with your healthcare team. So as Jill said, you should always feel comfortable calling your physician or the nurses about anything. We always talk about in our support groups that if your healthcare team is not hearing from you, they will assume that everything is going well. And we often hear, well, I don't want to be a burden, or, well, isn't cancer treatment supposed to make you feel bad? And there are a lot of assumptions that people make. Well, I'm supposed to be sick. I'm supposed to be nauseous. But really, your healthcare team wants to know what's going on so that they can manage your cancer, so that you can live with the highest quality of life through your cancer treatment and into recovery. So communicate. Lastly, hope can change over time. So we often identify hope as cure. So when people talk about hope at the time of diagnosis, a lot of times our minds go to hoping for a cure, hoping to have treatment and be done with this. And we know that that's not always a realistic possibility, and that there are things to hope for no matter what, and that hope can change over time. So I often see people start with hoping for a cure and then realizing that their cancer is going to be a chronic illness for them. But their hope changes to, I want to be able to manage my illness and manage it in a way where I can really enjoy my life. And sometimes people have big hopes, like I want to have my cancer managed for 15 years. And sometimes people have small hopes, like I want to feel good for my daughter's wedding. So it really is individual. It can even be something as a day-to-day basis. I hope to be pain-free today. I hope to enjoy a walk today. I hope to be able to communicate openly and honestly with my family about my fears. So there are all kinds of levels of hope, and to think about hope in that way can really be empowering, and to surround yourself with other hopeful people, because it is something that's contagious. And that's not to say that people should not be realistic or open or honest about their fears and some of the more unpleasant feelings that occur. Actually, on the contrary, it's so important to express your emotions and finding ways and people to do that are healthy. But it is a way to find meaning and quality in each day when we look at hope a little bit differently. So here are some resources that have been put together by the cancer support community. And I'm going to turn this over to Rhea to wrap up the webinar, and we'll be taking questions.
All right, great. Thank you, Bonnie. So at this time, I'm going to open it up to the audience. Again, you can submit a question through the Q&A box to the right of the screen. Just give me a couple seconds and I'll poll for some questions here. All right. So, Alison, I know you had started talking about bendamustine and eribulin, I believe that's how you say it. Did you want to continue talking about those two agents?
I guess I'm happy to answer specific questions if someone has questions about those agents. They represent, they're just, examples of some of the many agents that we use for various different types of non-Hodgkin lymphoma. And so I'm happy to answer some additional questions.
Okay. All right, great. So we have a separate question here. Is there any evidence that certain kinds of foods help keep lymphoma in check? More particularly, is consuming alcohol a risk factor for lymphoma returning? Are there effective treatments available if lymphoma returns after you have R-CHOP? This is for either Alison or Jill.
I guess I can start, Jill, and you're welcome to add in as well. So as we don't have any evidence that a particular food is helpful, in protecting you against having a lymphoma come back. What I typically will say to my patients is that, when we're done with treatment, the focus should be on trying to keep your body as healthy as possible, and and focusing on eating healthy and exercising and getting a lot of rest, because those are all the things that are good for building up your immune system, and keeping you strong so that if you do end up needing treatment at some point in the future, you're just in as good shape as possible. I'm not aware of any evidence that alcohol increases your risk of lymphoma coming back, but I do think that it's important to drink alcohol in moderation. I'm not against. I don't tell my patients to stop drinking alcohol, but I just want them to try to it's just as far as keeping their body healthy, to try to keep it in moderation. As far as what are the treatments after R-CHOP? So it does depend upon what particular type of lymphoma we're using the R-CHOP for. The most common lymphoma we would use R-CHOP for is diffuse large B-cell lymphoma, and that's when we're using R-CHOP, the goal of it is to cure it. Sometimes if the lymphoma does come back, there is treatment that we use that we would consider to be the second line setting, and the most common treatment used at this point would be additional chemotherapy that is different than the R-CHOP, and then typically in that setting we would consider doing a stem cell transplant, and in particularly the autologous stem cell transplant.
And just to follow up on that, absolutely agree with Dr. Moskowitz on all of that. A very common question that we get is about diet and nutrition. It's important to note that a number of hospitals usually do have a nutritionist on staff, and that is absolutely a key person to meet with, connect with, and kind of work with you throughout treatment. The question we get all the time is, can I eat anything to raise my blood counts? Can I do this if I just eat liver for the next, 8 days straight? And that answer is no. It's just important for you to have an overall healthy diet. Definitely, some increase in protein, things along those lines can help muscle repair, things of that nature. But there's nothing you can do in terms of that intake that's going to help those counts or help in terms of that situation. So that's just important to know, because we do get that a lot. And in terms of the alcohol, just, to agree with Dr. Moskowitz on that, there's a lot of research in regards to the link between alcohol and development of disease. It has been linked with certain cancers, such as breast cancer. For example, compared with non-drinkers, women who consume an alcoholic drink a day have a very small increase in risk, and that goes up with the amount of alcohol consumed. But those are definitely conversations to have with providers, not to tax the liver unnecessarily, things like that while you're going through treatment. But again, I think it's just important to note, be open, be honest. If you're done treatment, no one's going to say don't have a glass of wine. It really is for kind of those extreme cases as well. So just definitely direct those questions to your providers.
Okay, great. This is for either Alison or Jill. How can you move and help circulate sluggish lymph fluid after chemo?
I'll let you tackle that.
Yeah, to be honest with you, I don't think there is anything evidence-based right now regarding that movement of your lymph nodes. I mean, really what comes to mind is dealing with lymphedema, and that's more of a situation that we see with a breast cancer population. It can be, I don't use the word common, but a side effect of a mastectomy or, some surgeries that are commonly done with breast cancer patients can be this lymphedema, which is really just misguided or errant circulation of that lymph fluid, which causes swelling in the arm. And for that, there are treatments such as wraps and different massage types of treatments, and really integrative care in terms of that. In terms of just getting that lymph circulation, again, nothing in terms of this Western medicine that we would recommend or, that's been shown. There are always studies and things going on in terms of that integrative medicine side, massage, acupuncture. That's becoming more and more of a scientifically evidence-based practice, and there are a number of research studies about that, but I can't tell you definitively, yes, you can do one thing or another to improve circulation. We just don't know that at this point and wouldn't recommend anything.
Okay, great. We have a question here. What % of patients will require a stem cell transplant? Do we have numbers on that?
Well, I don't think we can give an overall percentage. I mean, it more depends upon the type of lymphoma that someone presents with. So, for example, the most common type of lymphoma we mentioned, or the most common types are diffuse large B-cell lymphoma and follicular lymphoma. And for those types of lymphomas, we almost never give a stem cell transplant in the frontline setting. And in particular, for diffuse large B-cell lymphoma, many of those patients are cured with their frontline treatment, and so it's only a minority of those patients who will, potentially need to go on to be considered for a stem cell transplant. There are other types of, potentially really more rare types of lymphoma, for example, some types of T-cell lymphoma, where we typically do consider doing a stem cell transplant sometimes in the frontline setting. So I would say there are certain types of lymphoma there where 100% of the patients that I see, I'll consider a stem cell transplant as part of their frontline treatment. So it really does depend upon the particular type of lymphoma that someone presents with.
Okay, great. Bonnie, our next question is for you. How should I approach speaking to my loved ones about my needs?
Well, I think it really depends on your relationship, but usually we suggest, picking a good time, being sure to set it up in a very safe and open location, not open physically, but like an open heart. So set a time where things are calm. It's not like right after getting the kids off the bus and everybody's stress is really high and, things are crazy. Set aside a time that's calm and share with them, just say right up front, there are some things that I'm feeling, and I really want to be very open and honest with you, and, I want you to be able to be honest with me. Whatever it is that you want to say, but there may be some times when I want to talk, and there may be some times when I don't want to talk, and I really want you to know, that I'm not taking it out on you, and sort of come up with a plan together. So let's say that you're having a bad day, and you know that perhaps you're feeling maybe a little bit more cranky and you're not in the mood to talk. Then you guys can come up with a plan and say, right now is not a good time, I'll come to you when I'm ready to talk about this. Come up with a plan that works for both of you. Where it's challenging is when one person wants to talk about your feelings and the other person does not. So that becomes a little bit more challenging. And I just encourage people to be very honest about their needs and use a lot of I statements instead of saying, you need to listen to my needs or you need to do this or that. It's really important to say, I'm feeling like I need to be able to talk openly with you. I'm feeling this. I'm feeling that. That's a much safer approach. And if there are certain things that you know that you need to talk about or you're expecting it not to go well, it never hurts to talk to an individual social worker about your individual concerns. Just prepare with them a little bit ahead of time. And also, any counselor or social worker at your cancer center should be willing to meet with you and a family member ahead of time. I think it also depends on the age of the family member and your relationship as well, and what you might want to talk to them about and how that conversation might be initiated.
Great. Thank you, Bonnie. Alison, do you want to elaborate more about this answer here for does SLL eventually transform to something else?
Sure. So SLL is referring to small lymphocytic lymphoma. It's also it's the lymphoma variety of CLL, which is chronic lymphocytic leukemia. We basically think of them as the same disease, although one, we call it one or the other, whether it's more in the blood versus more in the lymph nodes. But either one of these can it's not common, but it can happen that they can transform into a more aggressive lymphoma, and particularly what they would typically transform into is diffuse large B-cell lymphoma. When that happens, then the treatment would be aimed at trying to get rid of the aggressive lymphoma component of that, and so we would use the treatments that we typically use for diffuse large B-cell lymphoma, something in the frontline setting, such as R-CHOP.
Okay, great, thank you. So are there any new treatments being tested now, and if so, what are the long-term side effects of treatment?
There's a bunch of exciting new treatments that are being tested in various different types of lymphomas. One of the some of the exciting groups of new therapies are immune-related therapies, or therapies that work by kind of getting our immune system to help start attacking our lymphoma. And these are drugs, for example, a name of these class of drugs are called anti-PD-1 drugs, which kind of work in a way of waking up your immune system to try to fight the lymphoma. That's one example. There's many different types of new targeted drugs that are being developed. Engineered T cells that are in the news for ALL are also being developed for lymphoma, and in particular, those are cells that can be infused that are designed to help attack the lymphoma. And so, I mean, these are just examples, because there are so many different types of studies that are going on. And as far as the long-term side effects, I mean, that's something that we don't know about the long-term side effects of some of the newer drugs yet, because we really just don't have the long-term follow-up for these drugs. And so that's something that comes with, first we learn from doing clinical trials, but really from when, we learn more about these drugs as they become approved, and as we, follow patients for many years and take note of side effects that patients have over many years. So sometimes we can guess what long-term side effects would be, but we don't always know what all the long-term side effects would be.
Okay, great. So unfortunately, that's all the time we have today for questions. But if you'd like to submit additional ones, please feel free to reach out to the cancer support community, and we can help field any questions that you have. So I just want to say thank you so much for your enthusiasm and questions that have contributed to making tonight's webinar a great success. Again, if you'd like more detailed information on non-Hodgkin lymphoma, please feel free to check out our website or any of the resources that were listed on this slide. We'd also, again, like to thank our speakers, Alison Moskowitz, Jill Vanak, and Bonnie Dockham, as well as our program partners for this webinar, the Leukemia and Lymphoma Society and the Lymphoma Research Foundation. And we'd also like to thank our program supporter, Spectrum Pharmaceuticals. So please feel free to take a moment and complete our post-event online survey, which you will be automatically redirected to. It's a brief survey, and we appreciate any feedback that you have. Thank you, and have a good night.